Hello, and welcome to Beyond the Limb, where we explore physical therapy evidence, expertise, and innovation in limb loss and limb difference care. I'm your host, Will Riddick, and I'm a physical therapist focusing on improving care for patients with limb loss and limb difference. In this episode, we're exploring a topic that often sits just beneath the surface of rehabilitation, but is deeply intertwined with everything we do as clinicians: grief, loss, and emotional coping after limb loss. While physical therapists are often focused on mobility, prosthetic training, and restoring independence, we also spend hours alongside patients during one of the most vulnerable periods of their lives. That places us in a unique position to recognize emotional distress, support coping, and help patients rebuild confidence and identity as they adapt to life after limb loss. Today, we'll talk about how we, as clinicians, can better understand grief after limb loss, how emotional adaptation unfolds during rehabilitation, and practical ways clinicians can support patients navigating these challenges. My guest today is Dr. Emily Hawkins. Emily has considerable experience in the acute care setting and currently serves as a clinical assistant professor and the director of clinical education and the Doctor of Physical Therapy program at Old Dominion University in Norfolk, Virginia. She teaches the program's psychosocial aspects of patient care course, and in 2025, she and two colleagues published the textbook Psychosocial Aspects of Rehabilitation, Enhancing Outcomes Through Compassionate Practice. Emily, thanks for being here.
Yeah, thanks, Will. Excited about this opportunity to chat and have others listen in.
Yeah. All right, let's start. Kind of give us a little bit about your background and kind of what led you to focus on, as we'll say, as your book is titled, like the psychosocial aspects of rehabilitation.
Yeah. I graduated from Old Dominion, where I teach, and it was kind of just this comedy of errors when I was a student and actually took that course in the fall of my third year. But what I realized when I got into clinical practice, that the things probably, I should have learned in that class were the things that I felt most uncomfortable and unprepared for. And as I was talking to colleagues, they're like, yeah, this is just something you learn as you go. And yes, this is some hard stuff. You get used to it after a while. And interestingly, I had the opportunity as an adjunct faculty member, so before I was full-time, to co-teach in that class. I was co-teaching with someone who had her doctor of psychology. She was really bringing, the psycho part, not psycho, psychological part of the course. And I was there to provide the physical therapy clinical relevance. And eventually it became my own course. I have the opportunity to co-teach with some incredible women who are just wonderful human beings. That's who we wrote the textbook together. And now it's my favorite thing that I teach, because ultimately what I hope our students get out of this is that they become better humans, and that they'll therefore be better physical therapists when they get that final grade in the course. So that's kind of what got me there. And then it's just really just been this passion project for seeing, that these are the things, they're soft skills, so to speak. But these are things that really make a difference in how much you can impact and connect with your patients.
Yeah, I have, not to mention any names, but I've certainly kind of seen, I think, some practitioners kind of reflecting back on like their educational experience and thinking of like their physical therapy education as a not soft skill experience, as like getting the kind of core, what they would describe as the core elements. Can you do an evaluation? Can you do your treatments? Can you do your documentation? Yeah, but I think this is one of those things that, I don't know, I think is often taken for granted, is almost seen as like something that, oh, like, as you mentioned, like, oh, you'll figure it out. Yeah. So, kind of going off of that, for somebody who is so focused on that, what's kind of your argument to, like, say, if you were talking to a colleague to say, hey, you should be bringing this into your curriculum?
Well, in terms of a curriculum, I mean, CAPTE, our accrediting body for all physical therapists and physical therapist assistant education programs, it does require psychosocial aspects of patient care. And that's it. It doesn't say what encompasses, what that covers. But I think you can look to the APTA vision statement that their vision for the profession is that we are optimizing movement. We're transforming society by optimizing movement to improve the human experience. And the movement part, yes, that's the knowledge, the skills, the physical therapy specific things that you're learning. But ultimately, it's the movement of a human, and that human is a whole person who has these psychological and social and emotional factors. And if you're not addressing that, you're really not going to connect with them and make a big difference for their whole human experience. And that is just incredibly rewarding and really important.
Yeah. To kind of get a little bit more kind of specific to our overall topic today, kind of just very broadly speaking, we've thrown out these terms and turned it sort of these psychosocial elements. Let's kind of just throw out like sort of like a pseudo case study out here. A lot of patients, no matter what they're going through, often are grieving something. Whether that's a lost opportunity, a lost function that they have. So coming at somebody who's just kind of like generally looking at some kind of loss or generally some kind of grief, what are some of these, like, how would you describe like what the emotional responses are to that, or what grief may look like in those times?
Most people, whether you're a physical therapist or not, you've probably heard of the stages of grief. And there's 5 kind of distinct components of grief, but we progress through all of those in a non-linear fashion. The way that you progress through those is really unique to each individual. And that includes denial, anger, bargaining, depression, and then ultimately acceptance. And so depending on where you're at in the spectrum or the continuum of care, I was in acute care. I saw a lot of people, fresh losses, either a loved one who died in the car accident that they were also in, or they got a diagnosis and now there's this loss of what they had expected could be. And so I saw a lot of denial, anger, depression, but on certain wards in the hospital, you got to see that bargaining of, oh, if I work with physical therapy, I'll be able to do XYZ. I'll achieve my goal. I didn't get to see a ton of acceptance in acute care, but hopefully in other stages of rehab, that's more the norm. But it is this emotional roller coaster. And in physical therapy, we have the great privilege, as well as just responsibility of having that front row seat to that emotional roller coaster of our patient, and really supporting them and being there for them through that process.
Yeah, and I could say certainly from the outpatient side is, that grief process certainly does continue into there. For many times we get to see acceptance, but not every time for sure. It takes, in some cases, years, from what I've seen at least. I was wondering. I often hear patients, and even kind of like in the clinical setting, talking about, for a patient who has experienced limb loss, that they go through and grieve the limb. Could you unpack that phrase a little bit?
Yeah. So first, limb loss is a loss, right? Like we need to acknowledge that there is, like I said, with a diagnosis, it's this kind of ambiguous loss. But with a limb loss, like there's an actual part of their body that they no longer have. So that is a physical loss, and grief is a natural response to that loss. So when someone says that they're grieving a limb, or the process that they're experiencing, you would describe as grieving a limb, that is a normal human reaction to that loss. One of the things that's kind of difficult about grieving a limb is that So, you think about when you've lost a loved one, sometimes you have mixed emotions about that of like, there's this stuff I really loved and appreciated about this person. And then there's this stuff that like is just heavy and hard to deal with, and some of our patients, like that limb they lost gave them a lot of pain, was the source of a lot of frustration, but ultimately like it's a part of who they are, who they were. And so that is a loss that needs to be grieved and dealt with. And unfortunately, we don't have funerals for limbs. We have funerals for family members and loved ones. We wear black. We have a memorial service. We scatter ashes and do things of that nature. That these kind of culturally sanctioned norms for how grief plays out and what bereavement looks like, and we just don't have that for limb loss. So grieving a limb is a normal part. It's a normal response to the loss. Unfortunately, we don't have a normal way of saying, as a culture, this is what it looks like when someone loses a limb and how we can help them accept that.
For sure. I've certainly had patients who, they'll call it like an amputation anniversary or an ampuversary, I've heard as well.
Yeah.
And I've had patients who've had mixed thoughts about that. It's like some of them who it's like, been able to look at that and say like, hey, I was going through this crazy medical crisis. I am alive. I've been alive this many years because of what happened. And on the flip side of that, then there's the hard ones of like, oof, I've been dealing with this for this many years, like the challenge of that. So, all right, so let's kind of focus a little bit on how the role that PTs can play here. So as we kind of mentioned in the intro, physical therapists, we have the distinct privilege of spending a lot of time with our patients, comparatively speaking, with other professions. How would you say that kind of like positions us as far as like our role in recognizing emotional distress or grief and kind of how we can be an active agent in that?
Yeah. So like I said, you've got that front row seat, and sometimes you're the one that's presenting the challenge that brings out some of these emotions. Hey, I need you to try to do this thing that I know when you still had your limb, you could do this more easily. And now I'm asking you to do it. And I'm making you confront the fact that you don't have your limb anymore, so recognize that sometimes you're the source of the frustration and you're the reminder. But again, that you get to see their tears of frustration. You're also the one that sees those tears of joy. And when they cry from pride at, look, I'm able to stand for the first time without having to use my arms. This prosthesis I've been working towards, I've got it. It's here. So, like acknowledge that you're going to see the spectrum of human emotion across an episode of care and be prepared for that. You talked about the ampuversary, the anniversary. I think knowing your patient's story and being mindful of some of those things will be helpful. Like if they tell you, hey, the anniversary of the accident or the anniversary of the surgery is coming up. Like, don't be surprised if their mood's a little bit different around that day. So kind of proactively prepare to provide more emotional support in that phase. And, I think we certainly expect sadness and anger. And when you see those things, don't run away from it. Help your patient understand, like, yeah, this is a loss. The way you're feeling is normal. And, you're not going to do anything for your connection with that patient if they get emotional over something and you just brush it off or try to ignore it and act like it never happened. So acknowledge it, be prepared for it. And those types of things are all ways that physical therapists can really prepare for the emotional side of recovery after limb loss.
I think that also kind of brings the challenge of it too, is as patients who, maybe sit in front of you and having, crying and being there with them, being present with them, and maybe being in that same situation yourself. I think it's a hard thing. It's a vulnerable thing to bring yourself to do, but I think it does certainly bring an incredible value towards that. What would you say as like, for therapists who want to be able to encourage this openness, who want to be there for patients, what would be some like strategies or some tips that you might recommend for, I guess, kind of being available, kind of being open to that?
One thing I would say is kind of think about your workspace and what opportunities you have for, if we are obviously in an evaluation, if you're in a private treatment room or you're more secluded, you're asking questions that might bring out more of those vulnerable moments or difficult moments. And so think about the ways that you can position yourself, physically within your environment to facilitate your patient feeling safe, and you also feeling safe to have a reaction of, if you're going to feel, be tearful when your patient gets tearful, and those types of things. So like, know your environment, and you also need to know yourself. And this is one of the reasons I think it's probably, you just get it with experience. We don't want to do that hard work of self-assessment and reflection, but think on patients you've had in the past, or as you get them, take that moment and pause. Like, how did I feel in that session when the patient said this? What was my response? And be willing to do that self-work for the benefit of your patient and ultimately your benefit as well. You'll be a more satisfied provider, and you'll have a more sustainable professional career if you take care of yourself and monitor yourself in that way. And I think a physical therapist also needs to have a growth mindset for themselves, just like they learned the pre-prosthetic exercises and the pre-gait activities, the ability to respond to a patient and to support them emotionally as they navigate loss and grief. Those are skills that you can also learn, and just commit to doing the work.
Yeah. I mean, and like, as a phrase that we were using earlier, soft skills. I mean, it 100% is a soft skill. I'm even thinking of a patient that I had in clinic today, who, was really particularly going through a really challenging moment. And already it was a complicated situation in terms of like managing like the time, like the evaluation that was happening, all these like different factors that were going on at the same time, but also being able to also have that almost like cognitive capacity to be present with them and to do that. That's another thing to kind of throw on top of there. So it's certainly not something that's, I wouldn't say it's an easy thing, but it's a strong and important thing for sure, as we mentioned.
It is. Hannah, she wrote the most of the textbook, but she has this lovely habit of, in between her patients, she's in the outpatient setting. Her practice is that she goes over to her cup of tea, and that's her like mindfulness moment of like, I've supported that patient that just left, and I'm preparing for this patient that's coming next. So being aware too that like the emotions from one patient that you're building and generating, that's not having unnecessary overflow into your next patient who needs you at a different energy level and different emotional space.
We have patients who I think you could describe them as they wear their hearts on their sleeve. Is the way to put it, is that they will put their emotions on display. There's no kind of deep probing that has to be done. Like they present it to you. They're there, they're open. I think you and I, and I'm sure anybody listening to this knows that that's probably not the majority of people. For somebody, I maybe even step back from that. It's, what might be some signs that if we have somebody who's not necessarily presenting all these like emotions, where we, might expect for there to be grief, where, after having experienced limb loss or losing, somebody in an accident or something along these lines, something where we might expect to see some challenges and we aren't necessarily seeing those. What might be some warning signs that we would see? And as we are seeing those, how could we allow to kind of enter into that space with the patient?
Mm-hmm. I think before you start looking for warning signs, one thing that is helpful for patients, and this is across the board, across diagnoses, conditions, just telling them like it's common for patients to feel X. Or I say this to all of my patients. I'm not just saying this because you're in front of me and there's something I perceive about you. And
it's like setting the stage.
Set the stage. And then that might allow some of the emotions to be expressed, for concerns to be shared and that sort of thing, because you have said, not that I'm expecting you to tell me this, it's that it's common for patients with this condition to experience anger and to experience sadness. And if that's where you're at, let me know and we'll work with you and, take time during therapy to, address that as it presents itself, like just some of that blanket language to set the stage. But if you've done those things and then, there's warning signs, I think some of it's just that, like, they might have that sense of hopelessness and they might say something like, what's the point? And you might be like, well, I hear all my patients say that. But it's like, if that is their norm. I think another thing in terms of coping is the same thing as we look for with other patients in terms of like substance abuse. Like, are they turning to alcohol or other substances as a maladaptive, ineffective coping strategy, as a way to try to manage these really hard emotions that they're dealing with? So being on the lookout for some things like that. But yeah, really just like hopelessness, frustration, you're not seeing that buy-in. That could be that you haven't done your job as the therapist, or just that they're not in the emotional place to have that buy-in for participating with therapy.
Would you say there are any kind of like strategies that like practicing clinicians could like utilize, or kind of like be sort of almost like go-tos in order to kind of help patients through these things? I'm thinking particularly as maybe like the patient who every session they come in and just saying, man, I'm really having a hard time. And it, maybe even it's getting in the way of their contributions to the exercise that they may be doing, or to the activities they may be doing. And it's really, really kind of getting in the way of their progress within a session. What would be some kind of like tools that a PT could pull out of their toolbox?
Well, you already know how to assess strength, range of motion, function, those types of things. So this data you're already gathering to justify your skilled therapy, use that not for the insurance provider, use that for the patient to show them this is where you're at and this is the progress you've made. I know this is hard work, but look at what you've done. Or, you told me last week that it was easier for you to get into the grocery store and shop with your grandkids and pick up those animal crackers that they love. So being good students of your patients and knowing what are the things that make them tick, knowing this is the progress they've made, this is how that progress applies to their goal. You already do those things, but just doing it with more intentionality would be one strategy to really help. And just exploring things with a lot of curiosity. Like I hear you saying this a lot, that this is really hard and you just don't know if you can keep going. How have you coped with other really difficult situations in the past? Are you using some of those same strategies now? If they're a person of faith or, spirituality, those are things that they can tap into that you're not necessarily, telling them they need to do that. But if that's something they've relied on in the past, that's something that can support them in coping and managing the challenges they're experiencing at present. So asking those questions about how they've managed other difficult times in their life, and just encouraging, if this worked for you in the past, if you're not trying it right now, I think you should try that now. And then obviously, if something feels really outside your scope of practice, phone a friend, refer to someone who can really provide that specialized social and emotional support that they may need.
Yeah. And so I happen to work in a setting where we have inpatient and outpatient. So on our inpatient side, we happen to have rehabilitation psychologist.
That's great. Yeah.
To support them, at least while they're in the inpatient setting. For me, unfortunately, in our setting, they stay in the inpatient setting. And so I think it's a little bit harder sometimes to draw that line to say, I think I need to refer you here. If you were kind of mentoring a PT and, they're talking about a patient, what might be some things that you might hear from them or from a patient that would say, I think this is where we need to kind of bring in some additional support. Maybe seeing somebody like a rehabilitation psychologist.
So like I said, grief is a normal process. There are those 5 stages, and typically grief, about a year is how long it takes to get to some type of acceptance. A lot of times it's like experiencing the first of everything after a loss. Like you said, the first anniversary, the first Christmas, and that I wasn't able to do XYZ because of this change in my function. So being mindful, again, everybody progresses at their own timeline, but if you're working with this patient and it's well after that year and they're still experiencing these really heightened emotions, that to me would be a warning sign. And then again, just this that the grief and the hard emotions they're carrying, whether that's sadness or anger, it's interfering with their daily life. It's one thing if they come to physical therapy and this is hard because you're pushing them to achieve more. It's another thing when they are having difficulty getting out of bed because they feel that sense of hopelessness and despair all day long. That there are relationships they typically engaged in, they're pulling away from because they want to isolate and they don't want to have to be around people. So anything like that for any patient, not just an individual with limb loss, would be an area where I would be like, yep, this is solidly outside my scope of practice. I'm going to phone a friend and make a referral. And again, you have a really unique and advantageous situation of having those rehab psychologists. And if your patient was with them in inpatient, when you encounter them in outpatient, there's hopefully that foundation of readiness and something that you can refer back to. If you don't have that, whether you're in an inpatient setting or an outpatient setting, know your resources, be prepared to offer this. If you know this is a population you work with and something you're needing to make a referral for on even a, somewhat routine basis, just go ahead and have some trusted referral sources that, and then once you make the referral, monitor, I referred this patient, they participated in therapy, and they said it really helped, so that we're not just providing referrals and not monitoring those referrals actually benefiting our patients. So have that pool of trusted resources, or ask them, again, being curious about them, have you received mental health support or, counseling in the past? Do you have an established provider that you already trust? That would be a great place to start as well. You don't have to refer them to a rehab psychologist who's necessarily specializing in it. There might already be somebody on their bench in their past that they can more easily connect with and get some support.
I'm a particularly big proponent of building a care team,
Mm-hmm.
both from a patient side, but also as a clinician side of things. So, in the
Mm-hmm.
same way that you might have a good connection with, a patient's prosthetist or their
Mm-hmm.
physician, in the same way, bringing in somebody who has some mental health expert to be able to bring that into, I think,
Mm-hmm.
as another important aspect of that care team.
Mm-hmm.
Some other things, and thankfully, this is something that has really grown and is a strong presence within the limb loss, limb difference community, is like peer support
Mm-hmm.
systems. Um, you know, Different things like let's say peer support, or even going into like some like the community, different connections they might have in community, or like just getting out and being like in adaptive recreation, somewhere where they are with
Mm-hmm.
other people who've kind of gone through the same thing
Mm-hmm.
as they have. How would you say that plays in that recovery?
Mm-hmm. It can really facilitate the acceptance piece because they don't feel alone and they see individuals with similar losses demonstrating a new identity and living out acceptance of, again, this similar loss, that like, oh, this is what's possible. And that being something that's more concrete than like the abstract thing my physical therapist told me I might be able to get to. uh, Especially if there's for the peer mentor, like when you get to that point, like you've got a new purpose of like, I'm using this loss, the silver lining of my loss is that I'm helping somebody else navigate theirs. So that's just really tremendous, if for someone to get to that point. And so like providing them opportunities to help somebody understand and to say like, yeah, I felt pretty similar. Or, you know what, I had that same problem with that insurance provider. Here's how we got around it. Like some of it's just really practical stuff that the limb loss community, like, you know it, you live it, you look out for each other. So that's one really practical aspect of the peer support. It doesn't have to be all touchy feely, like, I accepted my loss and you can too. Like, no. So much just really practical. Like, yeah, how do you pack for vacation? How do you get through the airport with all this gear you now have so that you can go swimming and hiking on vacation?
I always tell folks sometimes it's just nice to have somebody to sit there and be like, man, this sucks.
Mm-hmm.
And they
Yeah.
are all for it. It is,
Mm-hmm.
yeah. And I get that in the
Mm-hmm.
lobby. But yeah, and with peer visitors, our peer mentors, peer visitors as well.
Mm-hmm.
And I've had the great pleasure of being able to see patients go from that initial after amputation all the way through to becoming peer visitors themselves. And even today, I get patients all the time that'll say, oh, yeah, I met this great guy. His name's David. And I'm like, oh, no way. Is it this guy? Is it this one?
Uh-huh.
And they're
Yeah.
like, yeah. He's like, you know him? I'm like, oh my gosh, yeah.
Mm-hmm.
It's always something really exciting.
Yeah,
So
we're
to see
well,
that.
we're built for connection, and so that opportunity just really highlights that. I think one thing, because like your patients can tell you it sucks, but what they might fear is that you're pitying them.
Mm.
And so for a peer mentor who like has lived it and that's their experience too, much less likely to have that concern about feeling pitied. That it's like they're receiving my it sucks because they know it, because they've lived it. Not, yeah, this sucks and I'm glad I'm not you. Like, we never want our patients to feel that way, that we're looking at them with pity, or like, or at least I'm not them. Like, we never want our patients to feel that way.
Yeah, for sure. And I think that's the unique benefit that a peer brings to that table.
Mm-hmm.
So for sure.
Yeah.
Well, I guess, probably this is going to pull a little bit from your work that you've done,
Mm-hmm.
but as far as like, let's say we have somebody who, maybe kind of had a similar experience to yourself, who went through their schooling, through their training,
Mm-hmm.
and really has, maybe not the strongest foundation in terms of what we've
Mm-hmm.
kind of called the soft skills of this.
Mm-hmm.
Would you say that there's any kind of like great resources that you would point to, maybe a textbook, or or any kind of like models or frameworks that they could point to, that you could point to and say, this would be a great place to start.
Mm-hmm. So yes, there's a textbook. No, but we have one chapter in the textbook on loss, grief, and coping. It's not specific to limb loss at all, but it is specific. Like, we have taken everything and made it physical therapy specific to the degree that we can in terms of examples and applications. There's some cases in the textbook, so that would be one option, because unfortunately there's not like a ton that would be specific to rehab that readily comes to mind, but look for it. PTJ does have like a psychosocial subject, like you can search by that and those things will be there. But really things I've already touched on, like be curious, be prepared to extend compassion and caring to your patients, have that growth mindset for yourself, that this is a skill set that you can grow in, reflect on your patients, learn from them, ask a more seasoned clinician, like, hey, it seems like you have gotten more comfortable with this. What are things that you did? Or what are things I can learn from you? Be willing to like sit in on a support group if those are happening and those are available to you. We in class, I play a TED talk from Adrienne Hazlitt Davis. She was the ballroom dancer who was a victim in the Boston Marathon bombing. And she has this first video and she talks about like what not to say when you go see someone after a loss and they're still in the hospital and that sort of thing. And like a provider told her she'd never dance again. And that's just a really like powerful 15-minute video that again can be one thing. It's patient storytelling, and that can be something that you watch, learn from, reflect on, and carry with you into practice.
I'm like, it's been a while since I've seen that, but like even now I'm like getting like a little bit of goosebumps, like just thinking about like that story. It is really incredible.
Every year I play it.
Definitely worth, for any listener who hasn't seen it, 100% check it out for sure.
Well, and I think at the next conference when we were in Boston, she was the speaker, like the featured speaker. And so there's some physical therapy specific videos talking about how her physical therapist helped her like get into running and all this kind of stuff. So Adrienne Hazlitt, I don't know if you're listening, big fan. Thanks for sharing your story and making, again, like what seems like an abstract, like uncomfortable thing, like very approachable and real.
Yeah, for sure. Kind of my last question, and how I usually like to end this is, just this could kind of come from any kind of different places. Do you have, either a story of you, of how you've worked with a patient, or even as an educator yourself, like, maybe something that you've seen in students or colleagues that you would say is like a really great example of how, addressing grief or emotion, going through emotional coping with a patient has made like such a profound impact on a patient.
Like I said, working in acute care, I didn't really have a lot of opportunity to see patients. I just met them where they were. And I got to see like the patient with, complicated medical history, and they knew this amputation was coming. And they were at a very different place emotionally than my patient who was in a motorcycle accident, was unconscious, and they wake up and there's no limb. Like, right. So that's more about me being able to prepare and anticipate like where they might be at, just based on the chart review and my understanding of their condition and the type of physical therapist I'm going to be as I enter into that room. The thing that comes to mind more recently that it's more powerful, I teach this class in the fall, and I feel like I'm doing all this stage setting of like next semester when you're working with amputees, this might be what you think about, or next semester when you're working with patients who've had strokes, this might be what you're looking at. So we have this day for individuals with limb loss to come in, for our students to practice, learn about componentry, practice the pre-prosthetic exercises, practice pre-gait activities, and those types of things. So we had gosh, probably 7 or 8 individuals with limb loss in the lab at once, and they're surrounded by like 6 to 8 students each. And it's like story time. Tell me about your rehab process, but tell me about, what led to your limb loss. Where are you at now? What are the things you're able to do? What are things you would still love to be able to do? And I tried to prepare them. Here's some questions to think about. And as you're listening to your patient stories, be thinking, was this expected or unexpected limb loss? Do they really seem to identify as an amputee, or they're like, no, I'm an individual who's sustained a lower limb amputation, that like they don't want to identify as an amputee, and that's their right. But it was really powerful, like this one patient, he was that like medical complexity. This was a thing where it started with a toe and then it's like, you know what, like just go ahead and I'll be a transtibial amputee. Like, let's just go ahead, save me the pain. And this is probably going to be an outcome anyway. Let's go ahead and do it. So he chose it, and he had an opportunity to do rehab before he even had surgery to kind of prepare for it. And then he had surgery, and, he took his prosthesis and went swimming in Greece. Like, he's achieved a lot. And even still, like him sitting there and telling these students the story of his loss, like he got emotional. And this was 6 years ago that he had his amputation. It was about 6 years ago, because his rehab was complicated by COVID. Go figure. Couldn't go into outpatient therapy because there were no clinics open. But just seeing all across our big lab, here's 7 or 8 individuals with their own stories, and our students responding to them. Patients or individuals with tears in their eyes, or students with tears in theirs, but also just feeling really inspired and motivated. Like, oh, I get to help a person achieve that, prepare for their trip to Greece, where they're going to have to navigate a lot of uneven terrain. And they're going to have to figure out, where am I going to change into my different prosthesis so I can jump in the water and swim? Like, I get to participate in that. So that was just a really powerful experience, and just saying, like I said, just a diversity of emotion. Like, one guy's in there with like his amputee joke t-shirt, and this other guy really takes pride that he walks so well, you'd never know he's lost his limb. So there's just a lot of diversity in this population, and just a lot of opportunity to connect with them and support them wherever you find them on their journey.
And I think that kind of brings out this idea that as we bring in these soft skills, as you're kind of meeting patients where they are, that is a truly holistic care. Just as in this lab that you had, it was not just about the, having a patient in front of you and looking at a leg, or, measuring these things. It was looking at the patient as a whole.
Mm-hmm. Yeah. It awesome. was a good day. It was a good day.
Sounds like it.
Yeah.
Well, Emily Hawkins, Old Dominion University, thanks for being here.
Yeah, thanks, Will. I appreciate this opportunity.